So next, we have that guy Kryger, I think, as I was introduced earlier by Stacy Bobber. So that guy Kryger is going to come to the podium. And I'd like to just talk to you about our philosophy and approach to bladder exstrophy care, because I think it's a little unique. It's a lot unique. I think it's advancing the field of exstrophy. I think it is a platform for improvement and change in exstrophy. So I'd like you to know more about how we approach exstrophy here at Children's Wisconsin and how we collaborate with other institutions. And it's not the only way, though. I don't want you to think that I'm so closed-minded that the care you received at other institutions isn't equally perfect. But I think this is a philosophy and a platform that hopefully will advance the field of exstrophy just a little bit further and a little bit faster. So we work together with Children's Hospital of Philadelphia and Boston Children's Hospital to do surgery together and to share our information. We call ourselves MIBEC because it's a multi-institutional bladder exstrophy consortium. That wasn't a very creative nickname, right? But when we were gathering together time after time, they're like, we should have a name for our group. And somebody said MIBEC because it's multi-institutional bladder exstrophy, and the next person said, good, let's move on. And, and so without too much clever, mnemonic, we just said MIBEC is our name. But we work together and do the surgeries together. So when I do an exstrophy repair at Children's Wisconsin, I have surgeons from Philadelphia and Boston flying in, and we work together collectively as a team of surgeons. And similarly, me and my team will fly to Boston or Philadelphia for exstrophy cases. And by doing that, we have the collective wisdom of a team of surgeons on every case, and we advance our exposure to exstrophy because, as you know, it's a rare and complex condition. And if I only do this surgery once every few years, how can I really advance my knowledge and surgical expertise? But if I participate in 10 exstrophies a year, well, now, that's really a platform for me to learn faster, become better, and maybe become innovative in how we approach exstrophy. A lot of this mission was inspired by Dr. Mike Mitchell in our desire to be better exstrophy surgeons. He had really done one of the major advances in the field of how exstrophy is repaired in a single stage. And yet, we would listen to his presentations at national meetings, and yet a lot of us individually couldn't achieve what he was achieving. But we wanted to know more from him, and he was on the faculty here at Children's Wisconsin before I was. So we decided to engage him as our coach, and the team of surgeons from our 3 hospitals learn from him on every surgery we do, with him mentoring us and advising us still. Even though he's in a retired mode, his role as a mentor has become maybe even a bigger impact on the number of surgeons he can teach. So we hope to also create a platform that inspires other healthcare systems to maybe work together like we have. We're Boston, Philadelphia, Wisconsin, but maybe 3 other healthcare systems could form a similar consortium, and there could be a West Coast consortium and a Southern US consortium, and various centers of expertise working together in more collaboration, we think is a very innovative way to approach the surgical repair of exstrophy. We also, by working together, we have a lot more patients and experiences to share, which we can present at national meetings and share what we've learned with other pediatric urologists. We create videos of what we do so that they can actually watch the surgeries we do and how we approach them. and that can, of course, with technology, be shared across the world. And also we hope to train and inspire the next generation of pediatric urologists to learn from what we've learned in the course of our careers, so that the next generation picks up from where we left off and doesn't have to spin their wheels to catch up. They just go from where we are and keep taking it further and further. So Dr. Mitchell, one of his innovations was to do a complete primary repair of exstrophy in one surgery. Granted, there may be some other surgeries that happen after that, but the anatomical repair of the exstrophy, all the aspects to it, because it's more than just bladder, right? It's urethra, it's sphincter, it's genital area, it's ureters. There's all these aspects, there's pelvic bones. So exstrophy is not just a bladder phenomenon in isolation. And putting all these parts anatomically and as precisely back together as you can was his philosophy, that the development of the structures would become more natural and more successful. And so some of those aspects of the surgery maybe aren't so critical to you, but there were some anatomical things that he did differently than anybody else. And critical to his philosophy was that, as I said, a meticulous dissection and reconstruction of the anatomy would restore some of the cycling of the bladder, filling and emptying, which is what the bladder is designed to do, and that would naturally help it grow in a more natural environment. So, to achieve that, Dr. Canning was truly the inspiration for us to get together in the MIBEC group. He was a pediatric urologist at Children's Hospital of Philadelphia, great friend to all of us in the world of pediatric urology, a great inspiration. Unfortunately, he passed away all too soon on a Memorial Day bicycling accident a couple years ago. So we lost him tragically, and it was like losing kind of the heart and soul of your team. But he left such a legacy and had inspired us for enough years that we continue on constantly reminded of his impact. But he engaged Dr. Mitchell and said, Mike, we need to, do this differently. We need to do this better. And he formed together a collection of surgeons who all had a similar belief that Dr. Canning did. And we did the first MIBEC surgery together at Boston Children's Hospital on February 7th of 2013. It was a very snowy day. A Boston snowstorm, rather classic. And collaboration of surgeons is really what I think is one of the inspirations that is hard to achieve. It is hard to get surgeons from across the country together, to work together selflessly without anyone trying to be the big ego in the room, and to do it consistently and sustain it year after year. But as Dr. Mitchell said, collaboration is the mechanism to learn from each other's expertise toward promoting the goal of optimal care and outcome for rare and complex patients. Because without that kind of collaboration, you just can't learn a rare surgery very quickly. And so he's been a great inspiration to us. This frog is a picture I use a lot in my talks because it's such a beautiful example of symmetry and beauty and delicacy in the world. At the time, Atul Gawande is a big role model for physicians to start to rethink how they approach their training and their learning and how to become better. And one of the ways for a surgeon to become their best is to engage a coach. We finish our training after residency or fellowship, and then we go off and we become surgeons on our own. But yet learning shouldn't stop and teaching shouldn't stop with your residency. You need coaches to continue to guide and mentor you. And so it's critical to have this real-time coaching from somebody of expertise like Dr. Mitchell to coach us through surgery and have that real-time critique of your performance. In the operating room with Dr. Mitchell at the age I'm at, or having him on a video conference watching me and telling me, you might want to dissect a little more there. that is really valuable, and I continue to learn from somebody of his, and hopefully someday I will mentor somebody to become better too. Bladder exstrophy is the perfect model for that because it's so rare and it's so complex. So the group, Boston Children's, we have a select group of surgeons there. It's not every surgeon at Boston Children's in the pediatric urology program that does this. It's a select group so that they get the highest volume of experience. Dr. Bohr, Lee, and Dr. Lee, Dr. Ted Lee, you'll hear more from today. Similarly, at Children's Hospital of Philadelphia, we're happy to have Dr. Shukla and Weiss here with us today. And at Children's Wisconsin, this is our group, and they're all here, and you'll hear them speak today. But it's this kind of volume and dedication and expertise that allows you to assemble the resources for expertise beyond just the surgeons. Our orthopedic surgeons are a dedicated team. We rely on the same ones over and over for our osteotomies at each hospital. Our anesthesiologists are the same ones over and over. So when you show up for anesthesia, they're not looking at exstrophy like it's the first time they ever heard of this, and they understand what the anatomy is. Our intensive care team, when the surgery's over, you're not showing up like it's something they've never seen before. They know the care for a child after an exstrophy surgery in a spica cast and all the elements that are unique to that. We have a dedicated psychology team to help balance the emotional, psychological side of going through the experience like this. We have pediatric pain specialists dedicated who know exstrophy recovery. They know what osteotomies feel like to a patient and a bladder closure and being confined within a spica cast and how we manage the discomfort of being in that. We have a dedicated nurse practitioner. We have a dedicated pediatric nursing team. And so the resources of volume start to benefit us. So our approach is to standardize the surgery so that each of us isn't doing it differently each time. It's a scientific approach. We each do the surgery the same. And if we see an opportunity for improvement, we make an innovation in one part, and then we can judge the outcome over the next 10 surgeries. How did that help us? So it's standardization of trying to reproduce what Dr. Mitchell has, set out for us as a template. The collective wisdom I've spoken about in surgery is, I think, a really rare and valuable asset. It gives us a database that is accurate. We can include every patient and their outcomes into very meaningful presentations and research and reports. So much of research in exstrophy up until now is somewhat limited by the fact that it's rare and each person might do the surgery differently. So, you did it that way, but what does that outcome mean? Because that person did it that way, and you're comparing apples and oranges too much, and that's never very valuable in surgery. But if you can have a standard approach, present that, then you have a meaningful outcome from that, if it's in a high enough volume. So we can assess our outcomes, we can make adjustments and assess the impact of those outcomes and increase our exposure with surgical volume. I like this slide because I've kind of told you, but this kind of demonstrates how volume in a rare condition is really valuable. Because the more volume of a medical condition, the more rapidly you accumulate experience this way. And then the more you can create these fully dedicated teams to care for a rare condition. And then you can improve your process of efficiency, and you can, raise the capacity for subspecialization. We have an anesthesiologist who is the lead of our exstrophy surgery program. We have an orthopedic surgeon who's the lead of our osteotomies in exstrophy. The capabilities of achieving more patient engagement by having more volume. We can have more events like this to kind of create an opportunity for patients to go through this together. And I'm having a hard time reading from the screen. Time for my glasses to get adjusted. Better results, adjusted and outcomes achieved. So anyway, this is the value or the virtue of a high volume surgical experience, because then that all feeds on itself, and it just keeps feeding on itself and getting better and better. So this is what MIBEC has achieved. A lot of surgeons will do this surgery once a year, maybe less. But collectively, you can see how over time we have escalated our surgical volume with over 200 surgeries, 122 related to bladder exstrophy, 24 related to cloacal exstrophy, 41 related to epispadias, and then there are variants. And that's each of our hospitals' surgical volume. So this rapidly growing experience, I think, has value to advancing the field and the care of patients. Consistent team of surgeons, better teaching, better outcomes, and evolution of the procedure. I think maybe it's a bit redundant, but I love the picture because it shows the kind of banter we have before the cases. We have a pre-surgical huddle and we have a post-surgical huddle where we review our game films. We film the whole surgery, we edit them down, we look at our game films and say, let's look at that in a little more detail slowly. And we'll have very, professional and critical debate of each other. That's Dr. Canning and Dr. Mitchell really debating a topic that we were passionate about at the time. So, as I said, the studies up until now have been, retrospective, and everybody has a different definition of continence. And so when they say their patients are continent, it's like, well, what do you mean by that, And does it involve a catheter or not? And was the patient augmented or not? And are they just urinating naturally or not? So there's so much confounding variables in the literature. We wanted to clean it with a clear, well-defined, high-volume database. And we want to help our patients achieve continence in some form. And the critical elements that we feel very strongly about is that bladder capacity is ultimately key to achieving bladder control. That's one of the critical elements to achieve a dry interval. And early cycling of that bladder will profoundly impact that. But it takes years for the bladder to grow. And the bladder doesn't always know it's kindergarten, time to start kindergarten, and you want to be dry for kindergarten. Unfortunately, the bladder doesn't work on that time frame. So sometimes it takes years beyond starting school for that bladder to grow sufficiently. And it varies from individual to individual. Dr. Mitchell once taught me that a perfectly well done surgery doesn't always heal the same every time because there are patient factors involved in the bladder plate that you're born with. So it's equally critical to have strengthening of that pelvic floor muscle too. And again, pelvic floor strengthening and that muscle tone requires a very meticulous anatomic surgery, but it requires time to strengthen your pelvic floor. And a lot of muscle tone and fitness and strengthening may not happen until after puberty and some of those critical hormones for muscle strengthening kick in. I always tell my patients, to the little 5-year-old, I can have him do arm curls all day, but he ain't gonna build up big guns like Hulk Hogan, But after puberty and his testosterone kicks in, those arm curls turn into big muscles. Pelvic floor strengthening is the same way, We can teach you all the tools to strengthen it, but it may not be till puberty where the true benefits of muscle tone and core strengthening kick in. So there are so many elements to this. Meticulous anatomic dissection, I said, will allow a better chance for sphincter tone. And commitment. We preach a lot about dedication to these exercises and to timed, scheduled trips to the bathroom. And that takes a lot of work on the patient's part, and some patients aren't quite ready for that level of commitment. We've done a lot of scholarly output from this group. In 10 years that we've been together, we've had over 40 presentations at national meetings, 18 presentations internationally, 10 publications in major journals, 8 textbook chapters, and 20 instructional videos. So we've tried not only to improve ourselves, but to improve the world around us in their understanding of bladder exstrophy. And I think that's very meaningful, and it means a lot to me, because so much of this is a personal sacrifice, and a lot of it is a labor of love amongst us surgeons, and we've developed a great sense of trust and friendship that goes just beyond learning the surgery. And so Dr. Shukla and Weiss and Dr. Canning knew, how much we loved each other in the course of working on exstrophy together, and that's been very meaningful to me. Hopefully we have a lot of patient satisfaction coming out of this, and some of you may recognize yourselves in that photograph. Again, collaboration, in Darwin's words, in the history of humankind, those that learn to collaborate and improvise most effectively have prevailed. So it's a very fundamental thing amongst humans to collaborate, to survive. And I think MIBEC is collaboration at its finest. And so back to this beautiful frog picture. That is actually 5 women posed together in collaboration to form a perfect, symmetric, beautiful, feature of a frog. And I just think it just emphasizes what we're trying to achieve as well with our collaboration. So thank you all for being here today. We're going to go into some more specific details about all the aspects of exstrophy and what we've learned in our journey together.